Good morning. My name is Dr. Chandler. I am the Chief of Vascular Surgery at the Bronx VA, James J. Peter. I am trained in both general and vascular surgery. I am going to be giving an overview on abdominal aortic aneurysms and talk a little bit about repair. Aortic aneurysms can occur pretty much anywhere throughout the aorta, but they're most commonly seen in the abdominal aorta. An aneurysm is defined as a bulge or a dilatation of the vessel itself. Intact aneurysms cause no health problems. However, large aneurysms have a tendency to rupture depending on what size they have become. A ruptured aortic aneurysm is a medical emergency and requires immediate treatment. Risk factors for aortic aneurysms, the most common and the most important is smoking. Abdominal aortic aneurysm are usually uncommon in the young. Usually you'll see them in patients who are above the age of 60. About 1 person in 1,000 will develop an abdominal aortic aneurysm ages 60 to 65. And this number continues to rise with age. Currently, screening studies have shown abdominal aortic aneurysm occur 2 to 13% in men, 6% in women over the age of 65. However, almost 90% of the aneurysm identified are small. They're 3.5 centimeters in diameter and unlikely to burst. Some of the risk factors for abdominal aortic aneurysms are smoking, which markedly increases the size of developing an aortic aneurysm. The risk is directly related to the numbers of years one has smoked and following the years if one decides to stop smoking. Men tend to develop abdominal aortic aneurysm 5 times more than women. It is more common in the Caucasian population. People with other medical conditions such as coronary artery disease, peripheral vascular disease are more likely to develop abdominal aortic aneurysm other than the healthier patients. A family history of abdominal aortic aneurysm increases the risk of developing an aneurysm to the given offspring, depending on what kind of genetic mutations may exist, such as Marfan syndrome. The screening test for abdominal aortic aneurysm at this time is based on the recommendations from Medicare. These recommendations are based upon the increased risk of older men who have developed an abdominal aortic aneurysm, especially those who smoke and who have a family history of abdominal aortic aneurysm. The test used most commonly to identify this as a diagnostic test is an abdominal ultrasound. This is a painless test where a wand is applied to the abdominal wall. It is not invasive and it looks inside with ultrasound frequencies to see whether or not there is dilatation of the abdominal aorta. The screening test is recommended for the following group. Men from the age of 65 to 75 who have ever smoked should be screened 1 time for an abdominal aortic aneurysm. There's little benefits to repeating this screening after the age of 75. Men age of 60 or older who have siblings or parents who have had abdominal aortic aneurysm or have physical findings should have the ultrasound also. Currently, there is no recommendation for general screening for women. Women who have increased risk of abdominal aortic aneurysm, such as who have smoked, have family history, or other risk factors, should discuss their concerns with their healthcare providers. Although the risk of developing the abdominal aortic aneurysm is much lower in women, the risk of rupture in women is much higher. And some professional societies believe that one-time screening should also be offered to women. Most abdominal aortic aneurysms are small and do not cause symptoms. People without symptoms are usually unaware that they have an abdominal aortic aneurysm. Some aneurysms cause a noticeable small pulsatile mass near the navel or the belly button. This may not be noticed by the patient, but can be detected by the healthcare provider on a physical exam. Approximately 30% of the asymptomatic abdominal aortic aneurysms are discovered in this manner, and the other are discovered with CT scans, MRIs, so on and so forth. Some of the symptoms related to the abdominal aortic aneurysms are abdominal pain, which radiates to the back, or back pain. Such aneurysms are typically detected during an evaluation for pain. Because blood can pool in a part of the aorta that is bulging, some people develop blood clots inside the aneurysm. For another word would be the thrombus, latent aneurysms. If one of these clots breaks loose, it can end up clotting up a vessel in the legs. These are called symptomatic aneurysms. Most patients have little warning before a rupture occurs. However, they may sometimes develop abdominal pain and tenderness over the aneurysm, which is a predictor of rupture. Approximately 15,000 deaths occur each year in the United States due to abdominal aortic aneurysm, usually because they have ruptured. Once the rupture has occurred, the success of surgery is much lower, elective. Hence, we try to perform elective surgery as much as possible prior to rupture. Aneurysm repair is the primary treatment for aneurysms that are symptomatic or at high risk of rupture. Repair, however, is associated with risk of complication. The risk of elective repair are balanced against the risk of complications of untreated aneurysm. This decision requires understanding of the patient and its comorbidities along with the aneurysmal morphology prior to going ahead and repairing. Risks of rupture are listed at this slide at this point. The risk of rupture of a small aneurysm, something smaller than 4 centimeters, much less than the risk of rupture of a large aneurysm, something greater than 6 centimeters. In addition to its size, the risk of abdominal aortic rupture depends upon the rate of which the aneurysm is expanding. The evidence suggests that an aneurysm that expands at the average rate of 0.3 to 4 centimeters per year, or 1 inch, which usually equals 0.25 centimeters, the annual risk of rupture is estimated with the following sizes. Less than 4%, it's less than 5% risk of rupture. Up to 5%, you're looking at about 5%, up to a 5% risk of rupture. When you go up to 5 to 5.9, you're looking at 3 to 15% risk of rupture. Between 6 to 6.9, we're looking at 10 to 20% risk of rupture annually. And anything above 7, as you can see, now you're looking very astronomical numbers and should be repaired. These are annual risks of rupture. Sometimes when the aneurysm expands rapidly, which is defined as anything that grows over 0.5 centimeters over 6 months, or anything that has gone over 1 centimeter over 12 months, should be fixed sooner. There are other complications that can occur with aneurysms. An inflammatory aneurysm, which is a swelling and inflammation of the aneurysm wall itself, which may cause abdominal pain. Sometimes the aneurysms can eat, or they can actually get a connection between the vena cava and cause heart failure. Sometimes they can cause a connection between the small bowel, which is referred to as an aortoenteric fistula, and cause bleeding through the bowel. Thromboembolies, as we talked about earlier, where the emboli goes down the leg and causes numbness and cold and no blood going down to the leg. And the aneurysms obviously can also get infected. These complications can be limb and life-threatening when diagnosed and need urgent repair. Most people with aneurysms less than 4 centimeters are advised to not have immediate surgery, but rather to follow up the aneurysm over time. This is known as watchful waiting. Usually, it involves getting an ultrasound abdominal exam every 6 to 3 months, depending on the size of the aneurysm. On the other hand, most patients with asymptomatic aneurysm greater than 5.5 centimeters in diameter or expanding over 0.5 centimeters over the 6 months are advised to have their aneurysms repaired. Repair may also be recommended for patients who are at a greater, whose aneurysm is actually greater than twice the size of their normal aorta. Medical management for aneurysms does include beta blocker when they're very small to slow the expansion rate, but this has not been conclusively proven. Surgical repair can be either open or it could be endovascular. Most aneurysms are now repaired endovascularly. Open surgical correction of the abdominal aneurysm requires a larger surgery where there is a laparotomy involved, the abdomen is open, and the aneurysm is opened and a graft is placed instead of the aneurysm to give it inline flow. This surgery usually lasts up to 6 to 8 hours. It requires general anesthesia and is ridden with complications. Patients usually can go home after 7 to 8 days. Endovascular repair is a less invasive repair, as we saw today. Most of the time, we can do this repair without general anesthetic, which is very important. Now we can actually do this repair without any incisions within the hour. Patients tolerate it well, and they usually go home the next day once the device has been deployed into the aneurysm sac and excluded the aneurysm appropriately. Thank you for your time today.